time for the rest of the program. And so we're starting up with section 2, or the second talk, Our Patients Suffer Mainly from Feelings. Dr. Mark Solms.
So thank you again for the luxury of this expanse of time. It's the topics that I'm wanting to cover with you are vast, and even within in totality 2 hours that you've given me, I hope you realize I am only sketching in the broadest of brushstrokes a picture which is obviously much more complicated than I can convey in the time available. I want to say that especially in relation to what I'm going to be saying in the second half of the talk, which is 45 minutes long, unlike the first half, which was an hour and a quarter. It's inevitable in relation to psychotherapeutic technique and psychoanalytical technique. It's an extremely complicated topic with all sorts of caveats and exceptions and whatnot. So I'm not going to be able to do justice to what I'm going to be addressing now, which is, well, what are the clinical implications of what I've said to you? I can only do it in the boldest of terms. So that's already a statement in my defense. But now I want to make another defensive statement, which is that in the 45 minutes available to me, I want to try to teach you something. I want to try to convey something to you. You are my students, as it were. You're not my patients. I'm going to speak to you didactically that this is what we do, and so on. And I'm going to do it formulaically in order to simplify. And I'm going to do it didactically because this is a lecture. Why am I saying this? It's because I've heard it said time and again. Do you know Mark Solms lectures to his patients? Do you know that he teaches them what to do? And do you know he has these formulae that he applies? Please remember, you are not my patients. I'm going to speak to you as colleagues, and I'm going to speak to you didactically, and I'm going to speak to you overly simplistically, because it's a lecture. I'm a very good analyst. So here's the outline of what I'm going to do. Starting with the first point. I've already told you that there are two major implications of what I've said to you for our understanding of the talking cure. Those two implications arise from, firstly, the fact that the id is not unconscious. So the id and the unconscious are two different places. Therefore, our conceptualizations of the talking cure in relation to bringing words and representations down into that which is not representable or represented is not what we're doing. Consciousness is gushing up from the id, and the ego's function, the ego's task, cognition's task seems to be to manage this, to try to dampen it down, to try to get rid of all of this feeling. So we must be doing something different. The second is that when we do look at the unconscious, that is to say at non-declarative memory systems, which are something utterly different from the instinctual drives of the brain, those memory systems, the non-declarative memory systems, the way that they work, for the reasons I've already told you and won't therefore repeat, it is irreversible. The process of consolidation into non-declarative memory cannot be reversed. You cannot reconsolidate a non-declarative memory in consciousness. It just is impossible for the reasons that I've said. Therefore, we can't be undoing repressions. I say to my colleagues around the world, my psychoanalytic colleagues, I say, in psychoanalysis, do we undo repressions? They say yes. I say, is it true that the core of the repressed is the Oedipus complex? They say yes. I say, how many of your patients have remembered their Oedipus complex? And they gulp. Because, of course, none. They never say, oh, thank you, doctor, for reminding me, gosh, I wanted to, now I remember. It never, ever happens. So we don't undo repressions. It's not what we do. And this slightly caricatured statement that I've just made sets the tone for what I want to do with this now 40 minutes remaining. I want to clarify the difference between what we think we're doing in psychoanalytical therapy and what we're really doing. I don't believe I'm going to tell you things that we don't already know. In other words, I don't believe I'm going to say to you, as a result of these radical theoretical revisions that are necessitated by the evidence, we're now going to have to do something completely different from what we did before. In fact, what you're going to find in what I say is that I'm going to explain to you why we do what we actually do for the most part, and why it's so different from what we think we're doing. So I'm going to bring, I hope, greater conceptual clarity to what we actually do already. And I think that that's a good thing, to be able to think clearly about what you're doing, rather than to have myths about what you're doing. So that's my intention. It's not a radical revision of clinical technique. It's rather a radical rethinking of what we're more or less doing anyway. Why are we doing it anyway? Because it works. We just don't know why it works. So I want to make clearer why it works. The other advantage in doing what I'm doing is it translates into the language of the cognitive neurosciences in general what we're doing. And that's not just a translation into a language which is a common currency, which makes it possible for us to make sense to people outside of psychoanalysis and psychotherapy as to why we do the therapies and the therapeutic techniques that we do. It's not only a matter, which is not a small thing, it's a good thing to have a common language, to be able to say things that not only your own shul understands, that everybody has the same terminology. But it's also a terminology which is tied to research traditions, which opens these concepts to new evidence as we proceed, because what I'm telling you is the current state of the art. It's far from being the final story. So that's my opening remarks. So that's point one. So why have I titled this talk, Our Patients Suffer Mainly from Feelings? Freud famously said, hysterics suffer mainly from reminiscences. To translate that, Freud said, our patients suffer mainly from unconscious memories. In other words, there's things that they have learnt which are influencing how they're behaving, and they don't know what those things are. That's all that it means. Hysterics suffer mainly from reminiscences means that our patient suffering arises from unconscious sources. There are things that they've learnt, and they don't know what those things are. They're guiding what they do, and they don't know that they're guiding what they do. That's the source of their suffering. It's a play on that phrase, when our patients suffer mainly from reminiscences, when I say our patients suffer mainly from feelings. My reasons for putting it that way are twofold. It's not that I disagree with Freud's formulation. I hope you can see from everything I've said already that I believe deeply this is what's going on. Our patients have automatized. They've made predictions under difficult circumstances, mostly in childhood, when all the odds are against you in terms of being able to learn how to meet your needs in the world. We've made predictions which are immature predictions, which are prematurely automatized, which are childish predictions, which are bad predictions, and then because we automatize them, they're not subject to review, they're not subject to revision, and then we're stuck with ways of being in the world which are not in our best interests. That is the fundamental notion that our patients suffer mainly from reminiscences. But our patients don't come to us and say, doctor, there's something I'm unconscious of, will you please tell me what it is? What they say is, I'm only too conscious of this feeling. Will you please take it away? And we are on the same side as our patients. We're on the same page as our patients. We're speaking the same language as our patients. We have the beginnings of a therapeutic alliance with our patients. If we formulate the very same mechanism in terms of what is conscious to the patient rather than what is unconscious to the patient. Feelings, for all the reasons I've said to you, and by the way, in this regard, Freud agreed with me. There are many internal contradictions in the Freudian model which I'm not banging on about because this is not an arcane metapsychological seminar. But Freud agreed that feelings are conscious things. Freud said it's a nonsense to speak of a feeling that you don't feel. There's no such thing as an unconscious feeling. So what our patients are conscious of are their feelings. Our patients suffer from feelings. They come to us, they say, I have this feeling, can you please take it away? And if we understand that that's our job, that's our way of thinking about what is troubling our patients, then we're on the same page. Now, there are two ways in which you can respond to your patient saying, I've got this feeling that I don't want. Will you please take it away? Remember, I'm speaking to you didactically. Please, I don't actually say this to my patients. Okay? There are two ways of responding. You can either say, yes, of course, take this pill. It will take your feeling away. Or at least that's what it's designed to do. Let's hope it'll take your feeling away without too many side effects or withdrawal effects later. But the idea is, this will take your feeling away. And the alternative approach is to say to the patient, not in so many words, to say to the patient, I'm afraid it doesn't work like that. Your feelings mean something. That your feeling, the feeling that you're suffering from, we don't say this, okay, we think this. It's what lies behind what we say. The feeling that you're suffering from indicates that you have an emotional need that is not being met. That's what feelings mean. Just as hunger means there's a need that is not being met, so too separation distress, that is to say panic anxiety, or depression, that is to say despair, or irritable rage, etc. These feelings all mean something. And if a patient is suffering from a feeling, then what it means is the need that lies behind that feeling is not being met, which means the patient is doing something in the world which is meant to meet that need, which doesn't work. So going back to everything that I said to you in the first part of the lecture, that means the patient has recourse to a prediction, which is a bad prediction. It leads to prediction error, which is feeling. Just as if you're hungry and your prediction is, I'll drink some water, it won't take your hunger away because it's the wrong thing to do. It doesn't work. We don't do that by and large because it's not hard to learn how to meet hunger needs. But it's very hard to learn, for all the reasons that I've said to you, how to meet our emotional needs. Please remember, the word emotional need sounds like something fluffy. Remember, emotional needs are absolutely biological things. They are obligatory. Because you're a human being, each and every one of us has the 7 emotional needs that I spoke of, and they are inescapable. It's an unavoidable task of life that we have to learn how to meet those needs in the world and reconcile them with each other in a vast complexity, a vast array of contextually different and unpredictable situations. We have to find some way of meeting all of these needs in the world. And to the extent that we don't do that, to that extent we're going to suffer from feelings. Of course, all symptoms mean something. Cardiological symptoms mean something. All symptoms have a meaning. But there's a special meaning with psychopathological symptoms, which is that the patient is trying to do something. It sounds weird when you put it in sort of Freudian terms, you know, that there's a wish that lies behind the symptom, that the symptom is giving expression to an unconscious repressed desire, etc. If I can strip away all the jargon, just remember what I'm saying is that our patients are trying to meet their needs in the world, but the way that they're doing it doesn't work. So the symptom is an expression of the patient trying to achieve something. And that's different from a physical symptom. There is intentionality in psychological symptoms which does not exist in physiological symptoms. It's the fundamental difference between psychiatry and the rest of medicine. So the meaning of psychological symptoms is the distinction between symptomatic treatment. In other words, the patient wants you to take the feeling away, and God knows, by the way, those of you who are not psychoanalysts, you might not know this. We psychoanalysts, we start out as patients and work our way up. Okay, so I have every sympathy with patients who want their feelings to be taken away. I felt exactly the same way when I began. You don't want to be told, oh, it'll take you 5 years of lying on a couch and all of this agony. You know, of course, you want the feeling taken away. And I'm not sneezing at symptomatic treatment. Symptomatic treatment is terribly important. Think, for example, of the suicidal patient. It can be life-saving symptomatic treatment. Think of a deeply depressed patient who could never make use of psychotherapy unless you gave them symptomatic treatment in the first place, let alone psychotic patients for whom symptomatic treatment is all we have available. So I don't mean to set up another false dichotomy by saying, oh, psychopharmacology is merely symptomatic treatment. We must all go for heroic psychotherapy, which is causal therapy. I don't mean it in that sense, but I do mean it when I say that psychopharmacology is always symptomatic treatment. And The causal treatment is what is causing the patient to suffer from these feelings. That's the thing that psychotherapy aims to treat. This is why I spent so much time in my first hour and a bit telling you about those emotional needs, because we need to recognize them. It's not difficult. And yet again, remember, I don't sit on the edge of my chair with my recipe book ticking off which emotions my patient's presenting with. It eventually becomes automatized. But everything that you do for the first time, it is a little wooden when you do it in the first instance, until you get used to it. But this is what I do. When I have a patient, the first thing I want to know is what feeling are they suffering from. And it's not that difficult. First of all, because usually they'll tell you in the first few sentences, that's why they're there. And secondly, which is part and parcel of the same thing, because it's conscious. The patient knows what they're suffering from. It's the feeling. They just don't know why they're suffering from it. If you're able to identify that, if the patient says, I'm anxious, I listen now these days automatically. Do they mean fear or do they mean panic? Because those are two different things. You see what I mean? So it's a matter of identifying through the language that the patient uses and through the feeling in the room and the way the patient behaves, everything that they present to you. I'm trying to see what is the feeling that this patient is troubled by. What is the overwhelming dominant feeling that characterizes this patient's psychopathology? Because that tells me which of their needs is not being met, which in turn tells me where to look in order to find what is it that they're doing, what sort of thing is it that they're doing, because I know what sort of object relationship we're talking about. Like, for example, if, to use the examples that I just gave, if the patient has fear anxiety, it means that they feel under threat and they're doing something to escape the threat, and that thing that they're doing isn't working. As opposed to if it were panic anxiety, that means the patient is trying to re-establish a contact, a bond with their attachment figure. And what they're doing in order to achieve that isn't working. So there's a very different pattern, a very different constellation that I'm looking for once I understand, once I've classified, this is the feeling that I'm dealing with. So my diagnosis, as it were, and I use the word advisedly, I mean it. For me, the most important diagnostic procedure is to determine which feeling the patient is suffering from. Now remember, I know I'm simplifying. I'm speaking to you for 45 minutes. So there's more complexity, but this part of it is pretty darned easy. And it's one of my basic compasses. What feeling is my patient suffering from? Because that tells me which need is not being met, which tells me I must look for what is the thing that they're doing that isn't working. And I know more or less where to look. So that leads me to the task of psychological therapy. It's not rocket science when I say this. I realize that it's a very stark statement, and I say it after careful thought, but I really mean what I'm saying. The task of psychological therapy, and by this I mean most psychological therapies, not every single one, but most psychological therapies. The task of psychological therapy is to help the patient to find a better way of meeting their emotional needs in life. That's the task. That's the mechanism of psychopathology, is that the patient is unable to meet one or another of their basic emotional needs because they're doing something usually as a result either of childhood history or genetic endowment, and of course the epigenetic relation between these two things. It's not a matter of etiology. If a patient has a highly sensitized separation distress system because they're born that way, just like some people are born with big ears, so it's going to be harder for them to learn how to manage that need in the world, and vice versa if they happen to be more robust and resilient in that department. Regardless of etiological factors, the feeling tells me which of the patient's needs are not being met, and the task of the treatment, not through teaching the patient, remember what I said to you at the beginning, I'm teaching you, not the patient. The task of the therapy is to help the patient find a better way to meet their needs in the world. It's good to keep that clear in our minds, because God knows psychologial therapy is a bloody complicated thing. It's very difficult. Each human life is extremely complicated. It's so easy to get lost in the detail of all the trees and to not see the pattern of the forest. So this is why I'm giving these simple formulations, because I think that it really helps us to be able to see the basic structure of what it is that we're doing. And I believe in almost all psychological therapies, as opposed to psychopharmacological therapies, what we're trying to do is we're saying, this is the feeling the patient's suffering from. This is what it means, that there's this need of theirs is not being met. Let's see what is it that they're doing that doesn't work, because that's what needs to be changed. Now you'll see, if you've got good eyesight, that the next step is to speak about the task of psychoanalytical therapy. And before I go there, and because I'm going there, let me make clear that there's a difference between psychotherapy in general and psychoanalytical therapy in particular. And this revolves around whether the patient is able to think about what they're doing that isn't working. I made this comment in relation to one of the questions at the end of the last session. I said that in relation to the question about strategic, keeping things out of mind strategically, I said that there are a great many things that our patients can think about that they would rather not think about. And that's what Freud calls preconscious. What's preconscious is not is not neutral. It's not that we're willing to think about everything that we can think about with equal gusto. There are many things we can think about that we rather sweep under the carpet. That's not repression. Those things are not unconscious. And many psychotherapies, CBT is an outstanding example of how you think with your patient about, well, why are you doing this? Can't you see that doesn't work? Patient can see that it doesn't work. Well, let's try that. Okay, and that's fine. And I'm not in this game of psychoanalysis versus CBT. I am strongly of the view that there are, and the evidence speaks volumes, that CBT works. It helps a great many patients. And why, for heaven's sake, subject them to a much longer and more difficult and more expensive treatment if they don't need it? So I'm saying that there are many psychotherapies, CBT being the outstanding example, where you can think with your patient about what they're doing in their lives that isn't working, which is causing them to feel like this, and Bob's your uncle. There are many problems that didn't start when you were 3. There are many things that, shit happens throughout life. So, the task is the same. But it's not the same with those predictions, those things that the patient is doing that have become automatized into non-declarative memory systems. This is what we specialize in psychoanalysis, and I don't actually feel particularly happy that that's what we specialize in, because this is a bloody impossible task. Okay? These are patients who are incapable of remembering. That's the problem that I had. That was the solution I came up with. Thank you for reminding me. I mean, thank you, but no thank you. But I'm glad I've got you with me now. You're an expert in this. Metaphorically, I'm going to hold your hand and take a deep breath and think this all through again. In psychoanalysis, or at least in those patients who need psychoanalytical therapy, the psychoanalytical therapy is particularly directed towards those patients who cannot do that. It's not possible for them to bring it back to mind. In other words, the prediction that they've made, and repression, remember, I'm reformulating it on good grounds. Repression is in the form of a prediction, that it's an action. It's a thing that the patient does. I'm doing this thing, and I don't know why I'm doing it. I don't know that I'm doing it, and I can see no connection between that and the feeling that I'm only too conscious of that I'm suffering from. How do we treat patients like that? Well, those are the patients that we specialize in treating in psychoanalysis. So how do we go about doing it? I'm making good progress. This word transference, I'm going to now speak to you about what is called transference, and you will see it's nothing spooky. It's nothing weird. There's nothing hocus pocus. There's nothing outside of science. Transference is simply exactly what I've been telling you. The patient comes up with a solution, they automatize it, it's the best that they can come up with. It's not that good. All of the range of things that I told you about earlier, from addictions to PTSD to childish problems that you can't solve, and there's no point in carrying on thinking about them. So you say, I'm not going to think about it anymore, I'm going to do it like that. It is like that, even though it isn't like that. That's how it works, even though it doesn't work. That's what repression is. It's something that gets automatized, which really should be iteratively being reconsolidated and reconsolidated, because that prediction actually doesn't work. But at this point, and that's the distinction between repression and the rest of what is unconsciously automatized, is that it gets automatized anyway. In other words, it's illegitimately automatized. The repressed is what is transferred. In other words, that thing that the patient does, they do it over and over again, and you can see them doing it over and over again. They do it over and over again. Whenever that need arises, this is their go-to solution, except they don't realize that's their go-to solution. That's transference. That's all that it is. And as I said, there's nothing spooky about it, because that's how non-declarative memory works. The patient does something, and by the way, we don't learn to do things because we can. We learn to do things because we have to learn to do things to meet our needs in the world. That's why we have learning in the first place. Learning is not about storing memories about the past. Learning is about the future. How do I meet my needs in life? And so what is transferred is that which has been automatized gets automatically repeated in life. That's all that transference is. There's a nuance here which I want to make clear. Many people seem to think transference is something that happens between patients and therapists. Why should it only happen between patients and therapists? Transference happens all over the place with all of their object relationships. All of that is transference. And by the way, that was Freud's meaning of the term. Freud spoke of transference neuroses, meaning transference from the past to the present, from the unconscious to the conscious, from the primary objects to the present-day objects. All of that is transference. So now I come back to what I said earlier. I listen for I feel for what is the feeling that the patient is suffering from. That tells me which need is not being met, which tells me what sort of object relation, what sort of configuration I'm looking for. And then that's the transference. I'm looking for how are they responding to separation distress? How are they responding to fear? How are they responding to lust? How are they responding to rage, etc.? How are they responding to those dominance situations that go under the name of play in affective neuroscience? Whatever it, depending on what feeling it is that the patient's suffering from, I look for a certain pattern of behavior. And remember, again, I don't sit there with my Mark Solms manual. Okay, automatically I do this. And initially, if you try this out, it will be a bit Mark Solms manual-ish, but eventually it will just become your way of thinking, because it works so well. It's so clarifying and simplifying in this thicket of the mind. I recommend it to you very dearly. Okay, that's what transference is. It's just looking, what is it that the patient is repeating in the present? What are they doing within the ballpark that I'm looking for? Because I know which need I'm talking about. I know what kind of constellation I'm talking about. It helps me to not get lost in all kinds of highways and byways. It's much easier to see this is the fundamentally important constellation that the patient is repeating. Now, I want to say a few words about this, a few more words about transference interpretation before I proceed to my last 2 points. First of all, I've already said to you, one misunderstanding about the word is that it has to do with something between patient and therapist. It has to do with patient and their relationships in the present day, which they're repeating patterns. And as I said, the one that you're looking for is the one that's related to the feeling they're suffering from. And I've told you how you go about doing that. The pattern comes from the past. This is the second misunderstanding about transference. Many people seem to think that therefore the aim of psychoanalytical therapy is to reconstruct the past. And this is where that notion, the undoing of repressions, rears its ugly head. Remember, you can't undo repressions. The aim of psychoanalytical therapy is not to remember. Remembering is not an end in itself. Many people get lost down that rabbit hole, thinking that it's all about remembering, and then once you've remembered properly, then somehow miraculously your life's going to change. Of course that doesn't happen. Because, and let me tell you, here is the biggest resistance ever. Because you can't change the past. You can only change the present. This is what patients hate, that they have to actually change something that they're doing now in their lives today. That's the only way they're going to get better. So many patients love this idea of, yes, let's wallow in the past. Remember, I say again, it's not an end in itself. It's not therapeutic to remember. The purpose of remembering, and rather I should say reconstructing, because for the most part, the repressed bit, the patient can't remember. So it's a matter of putting two and two together and trying to work out, why is it that the patient is doing this weird thing? In other words, why are they setting about meeting this emotional need of theirs, which is causing them the suffering, in such a strange, irrational way that's doomed to fail? In order to be able to draw to the patient's attention what they're doing, and I'll tell you why we do that in a moment, in order to be able to draw their attention to what they're doing, you use your reconstruction to better see this is what they're doing and this is why they're doing it. So reconstruction, the past, that aspect of transference interpretation or transference analysis, is a means to an end where the arrow of time goes the opposite direction. It's using the past to understand the present to change the future. That's the purpose of transference interpretation. So now, why is transference interpretation so important? For the following reason. The patient cannot remember. It's not possible for them to bring their non-declarative predictions to mind. It's in the nature of non-declarative predictions that they cannot be thought. So it's a mug's game to try and do that. And as I said, that's an impossible task. So what do? This is what we do. The one thing the patient can see and think about is what they're doing now. Why? Because they're doing it now. That's not non-declarative. If you draw the patient's attention to the fact that you're doing this, they can say, oh yes, I see that. Why can I see that? Because I'm doing it. Here it is. I'm busy doing it now. I did it yesterday. That's not the same as remembering the original childhood situation that led the problematic situation they found themselves in then, which led them to come up with this cockamamie solution. That they can't remember because they've automatized it. That's the whole point, I say again, of non-declarative memory systems. That they can't think about. It's pointless in trying to think about it, except to get some idea about what exactly is it they're doing and why, so that you can show them what they're doing now, in the present, because that they can think about. You cannot reconsolidate non-declarative memories into short-term, into consciousness. It's not possible by definition. But you can get the patient to see, this is what you're doing now. So let me tell you, and remember again, I don't say to my patient, let me tell you in 4 points, but let me tell you, my colleagues, in 4 points, what a transference interpretation entails. Number one, it's saying to the patient, can you see you doing this thing over and again? Okay, that's what transference interpretation entails first. Can you see you doing this thing over and again? And remember, the way you find this thing that they're doing is in the way that I told you. Which feeling is the patient suffering from? That means this is the need that's not being met. That means it's this type of thing that I'm looking for. Let me see what they're doing. Oh, there they're doing it. And so you show the patient, can you see you doing this thing over and again? That's point one. Point two is, can you see this is why you're doing it? It's meant to meet that need. In other words, that's how you're trying to get, by always having a crisis. Can you see you're always in a crisis? I'm giving you an example here. This doesn't apply to everyone. Can you see you're always in a crisis? Can you see that this is how you get your object's attention and affection back? This is why you're doing it. So that's point two. Can you see? Number one is, can you see you doing this here, there, and everywhere, over and over again? And with me, it doesn't have to be with me. It's with their boss, with their lover, with their children, whatever. This is the thing that they're doing over and again. Point two is, can you see this is why? It's meant to meet this need. That's what it's meant to achieve. Point three, can you see it doesn't work? Okay, and point four, can you see that's why you're suffering from this feeling? That's transference interpretation. Can you see this pattern? Can you see what it's meant to achieve? Can you see it's not achieving it? Can you see the link between that and why you've come to me in the first place? This is the trouble that you've got, and that's why. That's transference interpretation. That's bringing the affect back into connection with the prediction. Not the original repressed prediction, but with the enactment of it in the present. Because transference is always enactment. It is repetition. It is doing something. And now the patient is able to think about it, re-problematize it, corticalize it, represent it in declarative working memory, and think their way through it again afresh with you as an adult. And under the new circumstances that they're in now, and have the opportunity to think, is this really the best way to meet that need? That's a transference interpretation. And when you make those interpretations, and if you make them correctly, it's a deeply moving experience to the patient because they see it. They realize, shit, this is what I'm doing. Fuck, this is why I'm suffering. This is what, it's a huge momentous thing. Snot and tears appear. And guess what happens next? They do it again. Okay, the next session they've done it again. So what do? Do you tear out your hair? Do you yell at the patient? Do you give up in despair? No. What you do is you make the same interpretation again. Okay? You did it again. And then you say, you did it again. And then you say, you did it again and again and again. Because that's what the patient is going to do. It's because you have not reconsolidated the non-declarative prediction, because you can't. The non-declarative prediction is still there, throwing up automatically, outside of the patient's control and awareness, the same stupid pattern, the same stupid prediction. It's automatic. It's not the patient's fault. That's how non-declarative memory works. So how do you change them then? It's by making the same interpretation over and over again. It's called working through. That the patient has to, we have a rule in cognitive neuroscience about procedural memory. The rule is that it's hard to learn and hard to forget. It's a slow, repetitive business. If you want the patient to consolidate a new way of meeting that need, you've got to do it over and over again. There's no two ways about it. Medical insurance, I know in this country they don't pay for psychoanalysis anymore. And I'm afraid that the healthcare funders are going to have to learn how learning works. You can't change it. That's how it works. You don't become like you are over years and then unbecome it over days. It's just stupid to expect that. So this is why it takes time. We have to have time in order to show the patient, you did it again, you did it again, you did it again. Eventually, the patient says, I did it again. I did it again. Okay, and then the final stage is, I'm doing it again. They realize as they're doing it, then they don't need you anymore. Okay, and working through carries on after the end of the treatment. The patient carries on. They always, and this is also why patients can get worse again. You can always go back to your old bad old ways, because that non-declarative memory, that prediction, is never going to go away. So why is there any hope of ever overcoming repressed predictions? The hope lies in the following. The single biggest reason is because the new way works. Remember, there's a need, there's an emotional need that is inescapable. You can't avoid it. You have to meet those emotional needs if, with the help of a psychotherapist and with your adult mind and adult circumstances, you're able to rethink, which is not exactly an impossible task. Is this really the best way to meet that need? Maybe I should do this. And you don't tell the patient what to do. The patient now has the option of being able to problematize how they're going about it and think up some new way of going about it. And to the extent that that works better, obviously they're going to have recourse to the better solution now that it's available to them. And so, because they repeat the new solution with your help through working through, so that slowly becomes automatized, and they prefer to use the new solution rather than the old one, precisely because it works, and precisely because it's better, because it's not being made under duress with a childish mind in a childish situation. But the working through cannot be avoided. Okay, so those are the main things. Well, one more thing I need to say, and I'm afraid it's not a simple thing, but those are the main things I wanted to say to you. I want to underline them before I say the not simple thing at the end. Psychoanalytical, or all psychological suffering is in the nature, for the most part, of feelings. Identifying which feeling you're dealing with tells you which emotional need is not being met, because that's what needs to be changed if you're going to have a causal therapy. The patient has to do something differently in their life in order to meet their needs than what they're doing currently. How you do that is, having identified what the need is, you look for what the pattern is that the patient's repeating in relation to that need and draw it to their attention. Then they're able to problematize it and come up with a better solution, which they then slowly automatize. and then they don't need you anymore, and then their lives are different. Unless things go really badly, in which case they regress and get worse again. I'm afraid one has to admit and remember that that can happen. There's a lot of empirical literature I'm not talking to you about. For example, if I can just put a little footnote here. For example, the sleeper effect that we found, and now that, thank God, we've finally got into our heads that we have to do outcome research in psychoanalytical psychotherapy. What we've learned is a very interesting phenomenon, and this is really widely reported, and it's repeatedly been found, that at the end of a psychoanalytical therapy, the patient not only maintains their symptomatic improvement, but the symptomatic improvement gets more improved after the treatment. And that's because of this working through, carrying on after the end of the treatment, in my view. That last bit is not empirical, that's theoretical. My view is that's why the sleeper effect occurs. But that the sleeper effect does occur is, I think, a massively important phenomenon. Okay, so that's how it works. Remember, in broad brushstrokes, I've told you that I think something which should be helpful and clarifying, both in terms of teaching residents, beginners in psychotherapy as to what we're doing, and also for us old codgers to start seeing, more clearly what it is that we're doing, getting rid of a whole lot of myths about what we think we're doing, and also remember that this has the benefits of connecting us up to the best sort of knowledge that we have about how the mind works today. I want to end with this complication. Freud, remember, said that we fall ill when there's the return of the repressed. The repressed can never return. So this is a misnomer. It's not possible. I mean, Freud wouldn't have had a word called preconscious versus unconscious if the unconscious bit could return. The preconscious bit is the one that can return. The unconscious never returns. It's how it works. Not as an article of faith. It's a matter of evidence and also a matter of what we mean by non-declarative memory, both psychologically and physiologically. What returns is not the repressed ideas, the memories, the predictions. What returns is the affect. That's what returns. So why do we say the patient falls ill when the repressed returns? In other words, when they're overwhelmed by the affect again. Surely they've been overwhelmed by the affect all their lives. Because repressed predictions are bad predictions, they never work. They're childish wishes in the sense that, fantasies in the sense that I'm making as if this is how things are when it isn't how things are. So always they won't work. Therefore the feeling will never go away. The feeling, in other words, the need that was meant to be met by that prediction is not going to be met by that prediction. Therefore the patient's going to suffer from that feeling. So what do we mean by the return of the repressed? This is where the concept of defense fits in. I believe that on this ground and on one other ground that I'm going to come to, we need to draw a distinction between repression and all other mechanisms of defense. I think we all love our daughters. When Freud's daughter wrote this book about the ego and the mechanisms of defense, and she made as if repression was just one among many, Freud agreed with her, but I'm not sure that she was right. I think that repression is this primary thing where the child gives up on trying to solve something because it overwhelms them and they can't solve it. Then, as a result of the repressed prediction not working, they're left suffering from the feeling. Defenses are what they do about those feelings, instead of revising the underlying prediction, because you can't. That's what repression is. Still, you're left with feelings. How you deal with those feelings, which is a second-order thing, that is what gives character or structure to the personality. That's how you manage the consequences of what you did under fire in the trenches when you had no choice, usually when you're very little. Those defenses can be very realistic ones that work very well, like sublimation, through to not such good ones like our borderline patients have recourse to, which Freud called narcissistic defenses, through to psychotic defenses, which are very unrealistic and never work. Okay? But to the extent that you're at this end of the spectrum, the narcissistic through to neurotic, through to healthy end of the spectrum, your defenses by and large might work. Some of them work terribly well, like perversions and addictions and eating disorders and so on from the patient's point of view. And they don't come to us. They get sentenced to come to us by their families or by society or whatever. But the point I'm making is that to the extent that defenses work, patients are happy with them. It's when the defenses fail them that the affect comes back. That's what's called the return of the repressed. And at that point, the patient comes for treatment. Therefore, we face the situation I told you at the beginning. The patient's suffering from a feeling, and that feeling identifies what's repressed. If the patient does not come at that point, and the defenses are more or less intact, it's a lot harder to see what the feeling is. And this is the point that I wanted to end with, that to the extent that the defenses are intact, to that extent, it's not as simple as I said at the beginning, but by and large, patients come to us when their defenses fail them. Now, why that's this? I said there's two reasons. The other reason why I wanted to end with this note on defense is that defense, unlike repression, and this is the other grounds upon which I think that we must draw this distinction, unlike repressions, patients by and large, I don't mean across the board and I don't mean always, can problematize their defenses. In other words, they can think about what they're doing in their defenses. It's not the same. They're not necessarily non-declarative defenses. You say to the patient, can you see you doing that in order not to feel this? Which is what a defense interpretation looks like. And the patient says, yes, I know, but I've got no choice. Okay? In other words, they can think about it. They just don't want you to go there. And this is also why patients can change which defenses they use over a treatment and over a lifetime. Defenses are far more malleable things than non-declarative repressed predictions. So, my dear colleagues and colleagues in the making, that's what I wanted to say to you. I've gone, I think, 3 minutes or so over time. Forgive me. It's a complicated story. This is, in very, very broad brushstrokes, what I think we've learned about the unconscious, that I think we need to take on board, and that I think has these implications for our conceptualization of what we do, and I think it makes the whole thing just a little bit simpler, just a little bit more rational, a little bit more evidence-based, a little bit more open to the world, and a jolly good idea. Thanks very much.
So it's my pleasure to introduce our discussant, Dr. Maria
Longmar. She's a psychiatrist. She's homegrown here at UCSF. So in addition to an MD, PhD in biophysics, she completed her psychiatry training here. And she's currently an analyst with a full-time psychoanalytic practice here in San Francisco, a training and supervising analyst and faculty member at the San Francisco Center for Psychoanalysis, SFCP. She's chair and co-founder of the PPTP program. That's the Psychoanalytic Psychotherapy Training Program at SFCP. And there are, I would wager there are a lot of PPTP members here. It's become an important part of our training in the residency program, or an important adjunct to it. She's co-chair of the curriculum for analytic therapy at SFCP, and she serves as on the Wallerstein Fellowship Committee there. And finally, she's the director of psychodynamic curriculum for the CPMC Psychiatry Residency Training Program. So it's a pleasure to have you with us, Maria Longmar. Thank you.
Well, thank you, Dr. Wolf, and to the Wallerstein family and the Wallerstein Committee, and of course to Dr. Solms for this very interesting presentations. So my time slot here is 15 minutes. There is no way I'm going to do justice to your intriguing ideas, many of them. So just to briefly touch on one issue, I thought I might discuss some of the potential implications of your work for clinical psychoanalysis as I understand it. So just as the field of neurobiology has evolved in recent times, the clinical theory and practice of psychoanalysis has also evolved since Freud first put forward his various hypotheses about repression and the dynamic unconscious and therapeutic action, transference interpretation, etc. So from a clinical point of view, it turns out that Freud's original model works well for one type of problem that our patients suffer from, and that is the problem of intrapsychic conflict that Dr. Solms has been talking about. So, examples. When something that I need conflicts with another thing that I also need, or something that I really want comes with negative consequences that I really don't want at all. So everyday examples of this include unwelcome situations like if I go to an out-of-town meeting that feels important for my career, I will miss my child's performance at the school play, or vice versa. Some ratio of guilt and frustration and satisfaction is inherent inside me in whichever choice I make. And this is the essence of unresolvable internal conflict. So, of course, there will be external conflicts to contend with as well, meaning that a different set of people will be hurt or frustrated or pleased with me, depending on which choice that I make. And one common psychological defense against intrapsychic conflict is to locate the blame for our dilemma in others, as in, well, they need to understand that I have to go to the meeting or to the play. I can't miss it. They shouldn't make me feel bad. Freud's model would emphasize that the magical thinking involved in that notion that if only other people didn't make me feel bad, there would be no problem at all. I would feel fine. So in Dr. Solms' model, that's the defense against the repressed kind of faulty prediction. Now, according to Freud's theory, this wished-for state of feeling fine does rely on repression and the defense against those unpleasant emotions of guilt and frustration. That's the guilt we inherently feel around pursuing our personal ambitions when this causes hurt to someone we love, or the frustration and the resentment that we inevitably feel toward our loved ones for all of the personal sacrifice involved in caring for others. So in this example, I'm speaking of the guilt and resentment that we feel with whatever choice we make. I should really have said that is the guilt and the resentment that are inside us, but we do not fully feel. Usually, this is what's defended against. And that is really understood to be the entire point of repression and defense, to not feel things that are unpleasant to feel. And from a psychoanalytic point of view, some degree of repression and defense is considered essential. Because if we were consciously aware of all the negative feelings generated by everything we are doing all the time, we would never be able to do anything at all. So Dr. Solms, in his presentations today, has raised the interesting idea that at a neurobiological level, repression involves the same mechanisms as all learning from experience. So that is, predictions for complex behavioral plans that are aimed at getting our emotional needs met are generated, optimized, and eventually automatized in the long-term memory systems. Automatization involves moving these optimized predictions from these overburdened short-term working memory systems, those 7-bit ones that he's talking about, to the subcortical non-declarative memory systems, where they operate completely unconsciously. And these automatized predictions that successfully fulfill our emotional needs leave us feeling largely undisturbed. I think classical psychoanalysts might say they are successfully repressed. To make your point, I think Dr. Solms would say they are successfully defended against. Okay, so Dr. Solms proposes that repression occurs when these prematurely automatized and therefore faulty predictions fail to meet our conflictual emotional needs. And this generates unwelcome affects, which disturb us at a conscious level. And then various psychological defenses are mobilized to mitigate this. Now, Freud was the first to suggest that there is a symbolic associative meaning that is disguised in the particulars of those consciously observable affects, defenses, and transferences to the therapist. And so he thought that analysis of these phenomena offered clues to the underlying unconscious conflict, which could then be interpreted and worked through in the transference. So Dr. Solms has very plausibly suggested that the reason this approach helps patients with intrapsychic conflict is because it contributes to learning. So that is, the re-experiencing and reworking of one's conflictual feelings in therapy helps to automatize better predictions for getting one's emotional needs met in the future. So the problem now of intrapsychic conflict here that we're talking about is one that we all have to deal with by virtue of being a human being on this planet. And Dr. Solms referenced the work of Pantkep, who has identified 7 innate emotional needs, many of which inherently conflict with one another most of the time. So learning how to get those needs met is certainly a challenge, and it turns out that the Freudian model of analyzing a patient's transference seems to work pretty well for patients who primarily suffer from this type of problem. However, one area of growth in clinical psychoanalysis since Freud's day stems from the recognition that patients also suffer from other problems in addition to intrapsychic conflict. For example, many patients have a history of chronic early trauma, which has had a profound and lasting effect on their psychic development. So if I try to translate the way I think clinically about trauma into Dr. Solms' model of optimizing predictions and learning from experience, I might suggest that developmental trauma could be defined as a situation in which the conditions necessary for successful learning from experience do not exist. So I have in mind situations where someone's parent, who largely controls the reality of the young child, is floridly psychotic or malignantly narcissistic, and they provide bizarre and erratic responses to the child's needs. Or where the caregiver is an abuser, meaning that the very person on whom the child's survival depends is actually a threat to the safety of and well-being of that child. So this does not just cause the problem of prematurely automatized faulty predictions, as can happen in the intrapsychic conflict model. I think trauma also disrupts and corrupts the actual process of learning from experience. So to follow this out a bit, we can think about the separation distress system that was referred to, one of the 7 innate emotional needs. This model states that a crucial developmental task under the influence of the separation distress emotional drive is to learn how to make the caregiver stay close. So what are the implications for learning if this same person is actually dangerous to the child? I think it means that the concept of caregiver, to whom the child is biologically driven to attach, would actually get defined as the person who is most dangerous to me. And subsequently, even a hint of experience of care would signal a looming threat. And those who appear to offer care, like therapists, would be perceived as threatening. So through the operation of the separation distress system, dangerous people would likely be sought out in future relationships in a form of traumatic repeat, thereby reinforcing this definitional confusion. In the intrapsychic conflict model, this would be understood as resistance to change. However, I would suggest that under conditions of early developmental trauma, this repetition stems from conceptual corruption around what a caregiver actually is. I say this because the capacity to generate predictions about how to get one's needs met and test them out and learn from that experience does not develop in a substantial way until after infancy. Until then, children are completely dependent on an other for the meeting of their needs. If the caregiver is psychotic or abusive, there is almost no lived experience of having one's needs met without concomitant terror or pain and confusion. Therefore, there is nothing on which successful learning could be based. There is no target to aim for in terms of generating and optimizing predictions. One is shooting in the dark, which incidentally is kind of what it feels like clinically to work with severely traumatized people. It is very hard to get one's bearings, and a lot of the time you have no idea what is going on. So I'll say a little more about that later. But in my view, it is this absence of the basic conditions for successful learning from experience that distinguishes the problem of developmental trauma from the more ubiquitous problem of intrapsychic conflict. So another factor that can disrupt the necessary conditions for successful learning is the problem of systematic cultural bias in our society. When the system is systematically rigged against you, it doesn't matter what you do. You always get the same result. It's like living in a Kafka novel or going to Vegas, like the house always wins. And this does not just create the problem of limited options for those in marginalized groups. It messes with the actual concept of cause and effect at a systemic level. If the house always wins, this corrupts the process of learning itself. So the devastating repercussions of this can certainly be seen in individuals, but also at the wider societal level. And I think this is partly why it is so difficult to transition from a rigged, oppressive system of government to one that is more egalitarian. There is an unconscious conceptual confusion around care and danger, good and bad, cause and effect, that is built into the cultural psyche. And this makes it nearly impossible to learn from experience and solve problems, individually or collectively. So while this is a much bigger problem than we can take up today, I think it certainly deserves greater attention in our psychoanalytic theory and practice. So in the final few minutes here, I want to touch briefly on the issue of therapeutic action and psychoanalytic technique in situations of developmental trauma. Analysts as far back as Sandor Ferenczi, who was a contemporary of Freud, recognized that the classical Freudian technique of interpreting intrapsychic conflict in the transference did not appear to yield benefit for many patients who had suffered verifiable sexual abuse in early childhood. In fact, they seemed re-traumatized by this approach. And over the subsequent 100 years, many clinicians have made similar observations, and multiple clinical formulations have been proposed. Most of these tend to converge around descriptions of an apparent rupture in the psychic structure of traumatized patients. Winnicott writes of a true and false self, Bion describes attacks on linking, and more recently, Hayudagarevich, following Ferenczi, suggests that in an early stage of complete dependence, annihilation anxiety aroused by trauma, quote, automatically evokes fragmentation and dissociation, which then become imprinted on the tender psyche, end quote. So obviously there are many differences in the clinical and theoretical underpinnings of these models, but all of them are trying to contrast these psychic ruptures in the traumatized states with the so-called normal repression, in classical psychoanalysis, normal repression, where there is some traceable dynamic relationship between conscious, preconscious, and unconscious processes. In traumatized patients, both conscious and unconscious processes appear disrupted, as does the dynamic relationship between them. So in this vein, I was very intrigued to read Dr. Solms' description of these automatized patterns that are stored in non-declarative memory systems, which are instantaneously triggered in a non-thinkable, non-updatable way. In particular, how the fear conditioning response, which he spoke about in the first hour, that appears to leave indelible impressions after only a single exposure. So importantly, there's no conscious memory of the inciting event, and it just appears as a blank or an absence with no apparent links. So when I read this, I think this is exactly how I would describe dissociation clinically. One is shooting in the dark, and the triggered fear response is visible. Now, it is notable how Dr. Solms' description of the fear conditioning response is nearly identical to Gurevich's description of how, in her words, annihilation anxiety, fear, causes traumatic imprinting of fragmentation and dissociation on the tender psyche. Fragmentation and dissociation, which are triggered all the time in traumatized patients, are not optimized behavioral plans. Nor can they be readily optimized because, as I suggested above, the process of learning has itself been corrupted by the trauma. Fragmentation and dissociation are also not particularly meaningful in the psychoanalytic sense. They indicate something bad is happening, of course, but beyond that, not much can be inferred or interpreted, because by definition, dissociation means there is a disruption in the associative processes that we rely on to make these links. So clinically then, this calls for a very different technique than interpreting a patient's conflicting emotional needs as they manifest in the transference. There's obviously a lot more that can be said about this, but I'll just say a few things in the remaining time here. The first is that the reason that you need different techniques beyond just interpreting intrapsychic conflicts in the transference is that there really is not a symbolically mediated transference to interpret in these situations. There's just a triggered dissociation response to contact with the therapist. So under these conditions, the therapist's main task will be to survive and tolerate the patient's overwhelming affect, to respond empathically, not interpretively, actually, in a non-retaliatory way, and to create a new experience for such patients so that they can learn what their emotional needs actually are. For instance, before learning how to optimize behaviors to, say, keep a caregiver close, these patients need to learn what a caregiver actually is. And for a patient who cannot play, as was referenced, the work done by the therapist is directed towards bringing the patient from a state of not being able to play into a state of being able to play. That's a quote from Winnicott. And so on with all of the basic emotional needs. It is a challenging process, for sure, that requires a great deal of forbearance and creativity. But I'll close here with a reminder that in keeping with Dr. Solms' model, our own clinical experience tells us that a patient can never unlearn corrupted definitions of caregiver, play, and so forth. And the process of building up new definitions is excruciatingly slow. However, as I'm sure many of you who have worked with such patients can attest, once the new definitions begin to develop and the patient can actually begin to learn from experience, there is an enormous potential for psychic change. And it is a privilege to experience someone coming into being in this way. So thank you, Dr. Solms, for your illuminating insights in this book.
Thank you so much. Thank you very much for those comments. I'm going to be very brief because I know you want to ask questions and we're running out of time. So I want to just say, first of all, sort of repeat something that I said already. What I've said in these 2 hours are massive oversimplifications. And that's a good thing because I'm trying to show the underlying basic principles and link them with the sort of mental sciences more generally to show where what we do in psychoanalysis and psychotherapy links up. So it's necessarily trying to take all of the complexities and the theoretical schools and all of the nuances and so on and bring it down to absolute basics. And that's for the reasons I've said. But of course, what you lose, then you need to do the same thing in the reverse. You need to then go back to all of the complexities of the psychoanalytical literature and so on. But it's to help it to not be just navel-gazing that we make this link that I've done. I think that much of what we've just heard, is in the nature of reminding me it's not that simple. There are also all of these complexities. So I want to say very briefly something about each of those. So the first is trauma. I absolutely agree that trauma is different from what I've described. And I'll explain in what way it's different. Repression, remember, and repressions happen mostly in early childhood for good reasons. That's when the child is most vulnerable. It's most incapable of being able to meet its own needs in the world. Repressions do not happen willy-nilly throughout life. Trauma does. Trauma can happen any time.